during the clotting factors of a preterm baby would be not developed as well. Because all of this will end up with secondary infection secondary to preterm birth. So the morbidity of the neonate would be due to organ system immaturity. So, however, in this in developed countries, ito ha, 95% survival would be for those weighing more than or equal to 1 kilogram or 1,000 grams of gestational age, or at 28 weeks for females and 30 weeks for males. So we have a better, the females have better survival when it comes to preterm birth. They have earlier 28 weeks better chances for them compared to the males. That makes the females um, stronger and makes the male counterpart weaker. Okay, so here's the table. I got it from the, take note ha, our source is Williams. However, this is, if you have the 24th edition, if your reference is 24th edition, there are minor but important difference or additional information in the 25th. Okay, so better make use of the 25th. And by the way, 26th edition is coming up. So here are the major short and long-term problems in very low birth weight infants. So prematurity goes with the very low birth weight infants most of the time. But in preterm births, we have the AGA, appropriate, small, large, as well as very low birth weight infants. Okay, so the primary organ that is affected in preterm birth with the pulmonary. Okay, so we have the short-term problems in there, the RDS, air leak, as described a while ago, and even includes apnea of prematurity. If they would survive, they are related to long-term effects of bronchopulmonary dysplasia. The lungs hadn't developed, the bronchial tree hadn't developed well, reactive airway disease, and even bronchial asthma. Next would be the GIT. Okay. Then immunological, CNS, that would end up with intraventricular hemorrhage, glucomalacia, and even hydrocephalus. The long term would be the most common would be cerebral palsy, hydrocephalus, and neurodevelopmental delay, as well as hearing loss. The ophthalmologic for the eyes, retinopathy of prematurity is an immediate or short-term problem because of exposure to high oxygen pressure. And eventually, if not corrected or checked on time, it will end up with blindness, retinal detachment, myopia, and strabismus. Duling sila. Okay. Next one would be the cardiovascular. What happens there? Hypotension, of course. PDA, because under the patent arteriosus, and pulmonary hypotension. And this would the pulmonary hypertension would have a long-term effect in the adulthood. Okay, and we have the renal, hematologic, and endocrinologic as well. So preterms would tend to end as hypertensive, diabetic, and ano ba? And some worse, that one, cerebral palsy. So we should know the threshold of viability internationally. But the threshold of viability actually would really depend on the country's the economic status, actually, the capability of the hospital, the NICU. Okay, for the threshold of viability. But it's good to know that we have to know the international threshold of viability nowadays. Okay, before it's just 34 and up, then it became 28 weeks and up, now then became 26 weeks and up. Okay. So the lower limit of fetal maturation, so compatible with extrauterine survival, is termed as threshold of viability. Okay, so in the US, of course, they are advanced, more advanced. So the threshold of viability, they would have survival at 20 to 26 weeks. Okay, among Asians, Japan would have the lowest threshold of viability at 23 weeks age of gestation. However, of course, even if they have the threshold of viability at that 20 to 26 weeks, the quality of life would be of great difference from the one who is higher in age of gestation, especially so for for late preterm. They have better threshold and the quality of life is much better by avoiding those the one that in the table that we have seen. Okay, so taking note of the threshold of viability of 20 to 26 weeks, the brain injury would be observed among those who were born less than 25 weeks of gestation, and death would be almost 100% or 99% if less than 23 weeks age of gestation. Okay, so this is from the 25th edition. Okay, so these are the general guidelines for obstetrical interventions for threatened pre-viable delivery. Okay, so this is not present in your 24th. Okay, I'll just show you the general guidelines. So what are we going to do to prevent those short-term and long-term neonatal morbidities in preterm birth? Okay, so we have the if so they are categorized if it is less than 22 to 22, 23, and 24 weeks and up. Okay, so what are recommended at 24 weeks? Actually, look at this. If it's already 24 weeks, they are more aggressive. That's what it means. Whereas in 23 weeks, you can consider because 23 weeks and below, the death is almost 99%. Okay, but 22 and less than 22, it's almost not recommended. Okay, because diba, lower age of gestation would entail death of the neonate. Comparing it to 24 weeks, and better ang chances nila. So, the rest are recommended. Okay, like your resuscitation, corticosteroid therapy, magnesium sulfate for neuroprotection, succulysis to prevent uterine contraction, antibiotics for those having GPROM, continuous electronic fetal monitor, especially during labor, GBS prophylaxis, uh, Group B strep prophylaxis, cesarean delivery for fetal indication like fetal tachycardia, bradycardia. Kaya pa? Okay. Sorry for that. And, of course, the aggressive resuscitation by maid intubation, etc. Yan. So, basically, the recommendations in the management, the general management of preterm birth would depend really on the age of gestation. Okay? Okay. So this is just a table to show the neonatal morbidity rates of the early preterm and late preterm. And the preterm, late preterm versus the term births. Of course, there are more morbidities in preterm births, even if it's 34 weeks already or late preterm compared to a term. So, therefore, what does it imply? As much as possible, we have to reach the term. A late preterm or much better term age of gestation before delivery. Okay? So, the adverse neonatal outcome is really strongly related to age of gestation at delivery. So, 77% in 24 to 27 weeks age of gestation and lesser in 34 weeks and beyond at less than 2%. Because they had developed already primarily, di ba? We said it's the pulmonary system that is affected. Because at 34 weeks, you start to produce your surfactant from your pneumocyte 2 or the organelle uh, uh, from the pneumocyte 2 cells of the lungs. So the other than the complications, we have other concerns like high immediate and long-term costs. Maintaining a preterm is very expensive because they need oxygenation, they need a respirator, mechanical respirator, they need incubator. Okay, until such time they can survive on their own outside of the incubator and out of the machine, the respirator. Okay. Then special education for the neonate or toddler later on, like speech therapy, etc. And of course, sometimes you have to have institutionalized care, so they tend to be in the NICU, neonatal intensive care unit, which is very expensive. Okay. According to ACOG, American College of OBGYN, uh, intentional preterm delivery should occur only if an accepted maternal and fetal indication for delivery exists. So you cannot do intentional preterm delivery. Like, for example, in this case, it's like eclampsia, ano pa, the HELP syndrome, wherein you are pushed to the wall that you cannot prolong the pregnancy itself. Okay, because the pregnancy itself is the cause of hypertension or HELP syndrome, so you have to deliver. Those are the most common indications. On the fetal side would be bradycardia or fetal distress or not reassuring fetal status, so you have to deliver. Okay, so we have the classifications of preterm birth, which is the spontaneous most of the time, 75%, and medically indicated at 25%. As I've said, hypertensive, hypertensive complications. Okay. So, what are the maternal risk factors for you to be asking in the history, associating in the analysis or discussion of the case, and to suspect when you have a case like preterm birth? We have the bacterial vaginosis at less than 16 weeks, periodontal infection, dental caries, prior preterm birth, pre-pregnancy of BMI of less than 20, malnutrition, inter-pregnancy interval of less than 6 months. The earlier the interval pregnancy would be would be a risk factor for you have to have preterm birth. Likewise, very prolonged interval would also give you give a risk for preterm birth. Psychiatric disorder, syempre, that's taken, they don't really know how to take good care of themselves. Cigarette smoking and gestational diabetes. So, if you have previous preterm birth and more preterm birth, you have a higher risk to have another preterm birth or delivery. Okay? Okay, here are the other contributing factors that may result to preterm birth. Pregnancy factors like vaginal bleeding, threatened abortion, abruptio, and placenta previa, as well as fetal anomalies, will increase the risk of preterm birth. Smoking, a decrease or increase in weight gain, those who are beyond the normal BMIs, illicit drug use as well. However, exercise is a contributing factor is in question because those are who are having regular exercises, they are not having preterm birth. Okay, yeah. So, uh, yeah, we have mentioned that already. However, of all this, the most important contributing or risk factor would be history or prior preterm birth. How about infection like bacterial vaginosis, prophylaxis in screening and treatment? It's not recommended yet. So there are different causes of preterm birth. The spontaneous unexplained preterm labor with intact membranes, those with idiopathic preterm premature rupture of membranes, the PPROM, delivery for maternal or fetal indications, and twins and higher order or multifetal births. Okay. So for spontaneous, we have the uterine distension, fetal distress, cervical dysfunction, and infection. Okay, these are the causes of spontaneous. So with uterine distension, there is increased contraction, associated proteins or the CAP genes, gastrin-releasing peptides, okay, stretch-induced potassium channel or the TREC1. These are the uh, these are the substances that they had found that is related with uterine distension that causes uterine contraction, okay, and would lead to labor. Whereas the maternal fetal stress, what they found out is that with the central adrenal endocrine in the placental adrenal endocrine axis, there is increased cortisol, increased corticotropin that would induce your contraction again. As well as they, with that increased corticotropin, there is also increase in estrogen. That would signal now the uterine contraction. Another is that they accounted would be there is premature cellular senescence of the decidua, so apoptosis. Okay, that would signal again contraction. Cervical dysfunction in the epithelial or the stromal, so that would dilate the cervix. Infection either transplacental, retrograde, and ascending, which is the most common route of infection. It's there is an there is a debate on the intraamniotic versus sterile intraamniotic inflammation. Why? Because they found out even if sterile, there are times that there is inflammation there causing contraction. Okay, how would infection would it affect contraction, cause a contraction with the endotoxin and cytokines? This would lead to uterine contraction. Okay. Also, in infection, we have the inflammatory response from your lipopolysaccharides, interleukins, and cytokines. Okay. But take note of the vaginal microbiota, the balance of vaginal microbiota, lactobacillus should be increased so that there will be the pH will be acidic, right? However, during pregnancy, it's a bit alkaline. Okay, so the lactobacillus would be decreased and there would be increase in Gardnerella causing bacterial vaginosis. The next one would be idiopathic preterm premature rupture of membranes. This means spontaneous rupture of the fetal membranes before 37 weeks and before the labor onset. Most common would be the infection, oxidative stress-induced DNA damage, and premature cellular senescence. Among the three, infection is more related with PPROF. Okay. So what happens there in the membranes are actually made of the collagen. Uh, with the matrix metalloproteinases, the MMPs, that would lead to prostaglandins, and prostaglandins would cause uterine contraction again, increasing pressure to the membranes. Hence, there would be spontaneous rupture of the membranes. Another is the multiple pregnancy because simply because of uterine stretching, more fetus, more amniotic fluid, bigger placenta or more placenta that would distend the uterus, leading to dilatation, effacement of the cervix, and causing preterm birth and even PPROM. Okay, so how do we diagnose now preterm birth, preterm delivery? We have the clinical diagnosis wherein there should be regular contractions before 37 weeks. What is regular contraction? For 3 to 4, 4 in 20 minutes or 8 in 60 minutes, producing a progressive change in the cervix with the dilatation of more than 1 centimeter and effacement of 80% or greater. However, if you read in your book, in Parkland or studies by the ACOG, they would usually send patients who have less than 1 cm or even less than 2 centimeters. However, they still deliver prematurely around after 3 weeks. Okay. But in general, the progressive change should be dilatation of at least more than 1 centimeter or it's open and effacement of 80%. Okay. Okay. So by history, if you ask the patient, it's not a reliable basis because the patient might not perceive the contractions because they might be confused with the Braxton Hicks contractions or the false labor contractions. So, how are we going now other than the monitoring of the uterine contraction? Okay, it would be the digital assessment of the cervix. However, it lacks reproducibility, especially if it's less than 3 centimeters and less than 80% effacement. So, how then are we going to diagnose effectively the preterm labor? So we can have the symptoms, combinations of symptoms, laboratories, and ultrasound. Okay, so when it comes to symptoms, they can perceive contractions, or sometimes they would describe it as pelvic pressure, menstrual-like cramps, watery vaginal discharge, and lower back pain. So in your history, again, these are the things that um, you would ask and would try to differentiate or um, extract from your patient. Contractions, pelvic pressure, menstrual-like cramps, or dysmenorrhea. At times, they would describe dysmenorrhea, parang dysmenorrhea, watery vaginal discharge, and lower back pain. Okay. So when it comes to cervical change, to evaluate that one, we have the cervical length and diameter now. However, take note there are times that there is asymptomatic cervical changes in preterm labor. Okay? Uh, the question now is that do we need to do cervical assessment in asymptomatic patients? So, meaning it's a screening tool that you do cervical change. Is it recommended? There is a question there. So we don't. It's not yet recommended to do screening of preterm labor by doing cervical assessment because they found out that there is no benefit nor it is harmful in asymptomatic okay. However, it would be a different story if you have symptoms. Okay. So one would be the cervical length, assessing the cervical length. And assessing the cervical length, of course, not digitally, not during IE, but however, It's either TABS or transabdominal ultrasound versus transvaginal ultrasound. What is recommended is transvaginal ultrasound um, because a transvaginal ultrasound, it would eliminate the effects of obesity, cervical position, and shadowing of the fetal parts. So if the cervical length is more of transvaginal ultrasound rather than transabdominal. So when do we do that? Whom they recommend and when do they recommend transvaginal ultrasound cervical length assessment? It is done after 16 weeks in a singleton and empty bladder. Ayan. Okay. So how else? So we have the symptomatology, ultrasound with cervical length. Others would be ambulatory uterine monitoring and fetal fibronectin, both of which it's not really highly recommended. For ambulatory uterine monitoring, they found out that it has no really impact on the management of preterm labor. Fetal fibronectin, it's for research only, though fetal fibronectin is found to be adhesive, adhesive of the placenta in the uterine wall. Increase of that would be also seen in other conditions. So at more than 50 nanograms, so it's not recommended as a tool really for diagnosis of preterm birth. Yan, preterm labor. So ano yung what is more so far with all of this would be symptomatology and cervical length. Okay. So to increase now the probability of diagnosing preterm birth, we have the biochemical markers could be the fibronectin plus cervical length by ultrasound, and combination of the two would lead to the detection of the risk for preterm birth. Ayan. So ito yung FFN. So this is just to show you that fetal fibronectin would be really increased at early age of gestation, and when it becomes relevant would be 22 to 35 weeks age of gestation. An elevation of more than 950 nanogram at 20 to 35 weeks age of gestation would be a significant effect. Okay. Okay, so they found out that 24-34, it's associated with preterm birth. This is just to show you the cervical length. So the shorter the cervical length, it would lead to preterm birth. Okay, a cervical length of less than or equal to 2.5 centimeters, this would result to higher risk for preterm birth. Okay? Yan, 2.5 is the number. Kasi ang normal na cervix ay 3. Diba? 3 and above. 3 to 3.5. So, this is just to show you that where is the external os. Asan ang external os? Ito yung inner, right? Okay, the triangular area of density, and then the internal os, itong V. Ito external, internal. Ito yung baby amniotic fluid. Okay. So, this is the cervix. Close pa siya. So, how do they measure the cervical length? You get three cervical lengths, and then you get the average. This is just to show you cervical funneling. Ito, nag-funnel na siya. There is protrusion of the amniotic membrane more than or equal to 3 millimeters into the internal os. That is funneling. So therefore, it means that there is beginning dilatation of the endocervical canal at the internal os. Okay. So you trust your vaginal ultrasound. Here, this is normal. These are all abnormal. The T shape, the V shape, the Y, and the U. Ito, palabas na. Okay. However, since we know now that cervical length will help us diagnose cervical dilatation or preterm birth. However, by Cochrane studies, it's not recommended to do routine screening of cervical length for those who are asymptomatic. Anyway, screening is for all patients. But when we say screening, asymptomatic or symptomatic, they are included in the population. So, their studies that are in their studies, it's not recommended for those asymptomatic. So, only for symptomatic. Ganun lang siya. Yan lang. Okay. So, combining the two, the cervical length and fetal fibronectin, it seems that it would increase the chances of diagnosing preterm labor. Okay. But if FFN detection is not cost-effective, mahal siya, and it's not readily available in any of the laboratories around. So having a normal result, what is a normal result again of cervical length? More than 2.5 and FFN less than 50 nanogram would give you the low risk of preterm delivery. Okay. So if you have normal results, you don't have to do interventions like tocolytics, cerclage, etc. Okay. So what we should do, less disruption of patient's lifestyle. Okay, don't ask them to have bed rest. However, this is the caveat. You already have, we said, if the cervical length is less than 2.5, if the FFN is more than 50, okay, that will lead to preterm birth. But a normal results of the cervical length on the fibronectin do not eliminate the possibility of preterm delivery. Okay, so you still need proper patient education and surveillance for occurrence of preterm labor. Okay. Okay. So what would be the decision? The consensus decision, labor is consistent with contractions with cervical change. That's the basis for preterm labor. Rapid fibronectin, fetal fibronectin is only screening for symptomatic. Okay, and TVS for cervical length would be an adjunct to FFN to increase the detection of preterm labor. Okay. So the decision to admit would still depend on the presentation, the discharge, when to discharge, transport. However, should be made within 4 hours. Okay, so therefore, what's the final? It's not a screening test, but rather cervical length and fibronectin would be only done to symptomatic. Okay, especially those with symptoms plus history of early spontaneous preterm birth. Okay. So we're done with the screening. Steroids na tayo. Okay. Other screening would be yung bacterial vaginosis screening. We don't recommend. Okay. Ano pa? Naulit na natin yan. Okay, how about the use of steroids in preterm labor? This is the most effective intervention to improve newborn outcomes. Okay, yan, steroid use. Because steroids would prevent neonatal death in general by preventing RDS, cerebrovascular hemorrhage, neck and ICU admissions, and systemic infections. Okay, so when do we use steroids? During 24 to 34 weeks age of gestation, wherein there is preterm labor, okay, and the tendency to deliver a preterm baby. However, beyond 34 weeks, stop na ba? We don't recommend steroids na ba if it's beyond 34 weeks. They found out that there's still use for more than 34 weeks age of gestation because in amniotic fluid analysis, they also still found out pulmonary immaturity among this group. So, ideally, it is typically it's given at 24 to 34 weeks age of gestation, but can be given also at less than 37 weeks, as simple as that. So, the types and dose and route, we have the betamethasone and dexamethasone. So, betamethasone, 12 IM every 24 hours for 2 doses. Dexa, 6 IM every 12 hours for 4 doses. So, both 48 hours. It takes 48 hours. That's why if we tokenize or prolong pregnancy, it's for 48 hours for the completion of the steroids. So which one is better, the Dexa ba or Beta? Of course, more expensive than Beta. Dexa is less expensive and more available. There were findings that betamethasone have greater risk to reduce greater reduction in risk of death compared to DEXA. And also, there is greater periventricular accumulation of the brain in DEXA. Yan, mga studies lang nila. However, in your book, they are equally safe and equally effective. Okay? Okay, so... Okay, when to administer to all women high risk of preterm labor. Okay, and unless delivery is imminent, meaning the patient will deliver in less than 1 hour. Okay, you may still give one dose. Ihabol mo. So 24 to 34. So even if incomplete course of the antenatal steroid, for example, you were not able to finish the 48 hours window to finish all, still beneficial, even if one steroid that is given. Okay. What are the contraindications of her steroid use? Maternal systemic infections like sepsis, septicemia, and they advise caution among those with chorioamnionitis closely related with PROM or PPROM. Okay. However, in use of simple PPROM, there is no adverse effect on maternal and neonatal infection. Okay. Ito pa. Among GDM or pregestational, take note that there is transient hyperglycemia with the use of steroids. Okay? And you have to analyze that steroid effects begins at 12 hours after the first dose and lasts for 5 days. So it's crucial for us to monitor the blood sugar baseline and then at 12 hours until 5 days if you make use of steroids. Okay? Tapos. Okay. Use of steroids in more than 34 weeks age of gestation, especially those with GDM, is important because of pulmonary immaturity in GDM that is found in fluorescence polarization test. Okay. In short, if you have GDM and it is more than 34 weeks age of gestation but less than 37, it's highly recommended to give still steroids because of pulmonary immaturity of the units of mothers with GDM. Uh-huh. Okay, how about single versus multiple courses? Para siguradong sigurado. Okay, one course is enough. Okay? However, however, you may repeat the course after 1 week. So it's not routinely, it's not recommended to repeat the course. That is what we call the rescue dose. So single course therapy is the one that is recommended, but if beyond 7 weeks, you can have rescue dose in one dose. Okay, na-explain na natin. Okay. Why they don't um, why do they don't recommend multiple courses? Because the long term effects they with multiple courses they found out or association of attention problems here ADHD and cerebral palsy were increased. So single course, but you can have a rescue dose of isa. Okay? Pa. Yun lang yun. Okay. Ito daw. Kasi may uh, there is a debate on the single use versus multiple courses. Okay. There's a good effect, immediate, but the long-term effect would be for multiple courses would be yun na, cerebral palsy, etc., and ADHD. So, the decision now, you give it to the senior staff for the decision. And when you repeat, it should be a single dose rather than the full repeated course. So yun yung rescue dose of single dose. And to those who are less than 28 weeks age of gestation and not 34 weeks. Okay? And also inform the parents. Okay? In your book, you can read the rescue dose there. Okay? Yan. Ano ba yung rescue dose? Single dose lang. Like for example, if you made use of betamethasone, then single 12 milligrams IM. Or DEXA, it should be 6 milligrams IM, single dose. After 7 days or beyond 1 week of the first course. Okay, so how do we prevent preterm labor? We can make use of progestational agents, progestins, cerclage, and bed rest. But let's see what the study would recommend. So, progestins, they would inhibit the oxytocin effect of prostaglandin F2 alpha, and they would stimulate alpha adrenergic receptors, increasing the alpha adrenergic tocolytic response. Okay, we have the 17 alpha hydroxyprogesterone caproate, which is given 250 milligrams IM weekly. This is the only one that is FDA approved. But however, there are products like vaginal progesterone at 100-200 milligrams daily, and which is the progestation would be it started 16 weeks and 20 weeks, 20 weeks for 6 days. Can be continued until 36 weeks, 6 days, or until delivery. Okay. They found out even if it is a progestin, there is no adverse effects like masculinization of the female fetus. That's their reassurance. Uh, ano, ano pa? Those are just studies. Okay. Okay. So they found out that the studies say that progestin agents would really decrease the delivery of preterms and consequently low birth weight baby. Okay. So the route of administration that is uh, ideal would be intramuscular. Okay? Pero in your book again, there are studies says that better daw yung vaginal because it passes the first pass, yung sa liver. Okay. So the recommendation of 17-alpha caproate, because ito lang yung study nila, singleton pregnancy with history of spontaneous preterm delivery, PPROM, and those who are asymptomatic but with cervical length of less than 1.5 centimeters. But some would practice even if less than 2.5 centimeters. They would give progestins. Ayan. There are no studies yet to be a supplement with cerclage used in asymptomatic but with positive fetal fibronectin together with tocolytic and therapeutic agents after tocolysis. Okay. So for its use, exclusion criteria in the studies would be multiple gestations. That's why they recommend only for singleton, isang baby. Short cervix and no prior preterm birth. Medically indicated preterm birth. Siyempre, ano mo na nga, may problem. So you don't really have to prolong the pregnancy. Fetal anomaly, planned cerclage, hypertension, and seizure disorder. Okay. So ito siya. But take note, 17-alpha hydroxyprogesterone caproate, the side effect would be the occurrence of GDM. Increased ang risk for gestational diabetes mellitus. So, yun ay watch out mo ulit. Another one, to treat preterm labor would be cerclage. Okay? It should be done in prior early preterm birth or those with history of mid-trimester losses. Okay, shortened cervix, and there is such a thing as rescue cerclage. May preterm birth na siya, immediate cerclage. Kung may rescue dose of steroids, we have also rescue cerclage. What is cerclage? This is as simple as doing a purse string on the cervix to close the cervix, literally. Okay? Ito yon. Ultrasound. Yun. Andito yung string. Again, there's a debate. Kung nakaka-prevent ng preterm, should we do prophylactic cerclage? Okay. The recommendation, no overall reduction in pregnancy loss and preterm delivery. So prophylactic cerclage is not recommended for those with no cervical length. Those with no criteria met, as mentioned a while ago. Ito, yung history and shortened cervical length. Ano pa? So, ACOG recommends cerclage among those who are singleton, history of spontaneous preterm delivery before 34 weeks, cervical length of less than 2.5, and a gestational age of less than 24 weeks age of gestation. Ayan, ang present. Sabot din ninyo yan. Okay, this is just to show you the algorithm. when to offer cerclage. Yun lang, napaka-simple. So you can expose everything. So you give 7 alpha hydroxyprogesterone cut through weight starting 16 to 18 weeks in those with recurrent preterm birth. Okay. Ayan. And then you monitor by ultrasound screening, ultrasound monitoring every 2 weeks. If the cervical length is equal or more than 3 centimeters, then continue monitoring. When the cervical length would be decreased with uh, reducing to less than 2.5 or 25 millimeters, then consider cerclage. And how about bed rest as a part of treatment of preterm labor? There is no um, evidence that it is beneficial. So we don't recommend bed rest. Pero lagi yung you always hear that, bed rest ka, bed rest ka. Ano kasi eh. Okay. And take note, in their studies, they found out that having bed rest would have complications even like your thromboembolism, especially if more than 3 to 5 days that they are immobilized, and bone loss. Okay, yan. Nagkaka-bone loss daw. How about tocolytics? 8:58, 1 hour na tayo nagsasalita. Tocolytics. When we say tocolytics, toco means uterine contraction. Lytics or lysis. You lyse or stop the uterine contraction. That's the meaning of tocolytics. Okay? Okay. So, as I've said a while ago, to reiterate that the main goal of tocolytics, why do you give tocolysis? Why do you stop uterine contraction? For the completion of the course of steroids, which is, again, salita na ako ng salita. Asan na ba? Ano? Junica. How many hours will you complete the course of steroids? Asan na si Junica? Yung mga hindi natapos sa exam. Nag-interview na about China. Bakit roof na ang pinapakita mo? Nagre-review ba kayo sa ibang subjects? Are you reviewing? For 38 hours. Okay, sige. So, your goal for tocolysis is to complete the steroid course for 48 hours. Okay? Ayan. That's why really they would recommend more than 48 hours na tocolysis, as well as maternal transfer to a tertiary level hospital for NICU facility. Okay? So that there will be allowance for them to still travel to the referring tertiary hospital. The secondary goal of tocolysis would be to reduce mortality and morbidity with severe prematurity, of course, because you complete the course of the steroids. So, steroids versus tocolysis, to prevent morbidity and mortality or severe prematurity, it would be the steroids. Okay. So, it's just a contraindications for tocolysis would be severe preeclampsia, abruptio, intrauterine infection like chorioamnionitis, lethal congenital chromosomal abnormalities, advanced cervical dilatation, which is more than 4 centimeters, fetal compromise like your bradycardia and tachycardia, and placental insufficiency. Okay, because there's no way to prolong the pregnancy in these cases. That's why it's contraindicated. Okay, prolonging would be detrimental to the health of the mother and the baby and would even end up with mortality. So no need to prolong. Okay? Okay, what are the different types of tocolysis? We have the beta-agonist like ritodrine and terbutaline, the calcium channel blockers, primarily your nifedipine, and then the magnesium sulfate. Marami pang iba. Okay. For beta mimetics are like your terbutaline. However, the side effects would be chest pain, dyspnea, tachycardia, palpitation, tremor, and headache, etc. That's why when you make use of terbutaline, isoxaprine, okay, you have to monitor the heartbeat because primarily they would complain of tachycardia. Ayan. And dizziness because of hypoxia. Okay? Ayan. As I've said, one example is terbutaline. How do we give it? 0.25 milligrams subcutaneous single dose. Okay? Um, for ano yun? So it causes smooth muscle relaxation or uterine muscle, and it has minimal effect on the cardiac conducting system compared to terbutaline. However, unless nifedipine is combined with magnesium sulfate, which would give you a cardiac arrest. So do not combine nifedipine and magnesium sulfate. Take note of that, ha? You will kill your patient. Okay. But comparing nifedipine versus terbutaline, nifedipine has lesser side effects. Okay? Okay, so it prevents the influx of every na-mention na natin. So it causes vascular relaxation. However, so you would think that when it causes vascular relaxation, it can cause hypotension. In the studies, marked in hypertensive patient does not occur significantly in normotensive patients. Okay, so it doesn't really cause vascular relaxation, symptomatic vascular relaxation like hypotension in normotensive patients. Okay? But it can cause a marked vascular relaxation in hypertensive patients. So normotensive patients, when you use nifedipine as tocolytic, it will not cause hypotension, but it causes hypotension or decrease in BP in hypertensive patients. That's in the study. Okay. Okay. Just studies na lang yan. Okay. That makes the nifedipine or calcium blockers preferred tocolytics more than the terbutaline. Okay? So how do we make use of nifedipine as tocolytic? We give 30 milligrams loading dose, then 10 to 20 milligrams every 4 to 6 hours. So yung JITs, 30 milligrams kasi yung nifedipine JITs. So we make use of that as our loading dose, and then 10 milligrams capsule, sometimes 10 to 20 every 4 to 6 hours. Nakuha? Okay. Oy, children, we are teaching you to become doctors. So you should know this dosage, the route, the effects, the adverse effects. Okay? Ayan. Okay. Okay. So it seems that nifedipine is a better choice as tocolytic versus betamimetics or the terbutaline, okay, and ritodrine. However, those who are planning to go to UK to practice, take note, it's not still licensed as tocolytic in the UK, yung nifedipine. So you cannot use the nifedipine if you practice in UK. Ha? Okay, so it's your responsibility now to monitor what is licensed and not. Okay, so that the ones that we studied that is better tocolytic, you can apply. Okay? Yan. So, contraindications for nifedipine: allergy, maternal cardiac disease, because it has a potential negative inotropic action. Okay? Yan. And hypotension in hypertensive, but not in normotensive, remember that, and hepatic dysfunction because it's the liver that's processing that. Okay, so no ang nifedipine in combination with magsulfate, and no to nifedipine those with cardiac disease because of the negative inotropic action. Okay, remember that, very important, because by simple nifedipine you can kill a patient. Okay? So, ayan na. Pala, nauna na ako. Kung current use with IV salbutamol, magnesium sulfate, because it can cause hypocalcemia, cardiac toxicity, maternal death. Transdermal nitrates, your nitroglycerin, and antihypertensive meds. Okay? How about magnesium sulfate? In summary, huwag na yung basahin yan. Magnesium sulfate as tocolytic is not recommended. Okay? However, what's the role of your magnesium sulfate in preterm labor? It's for neuroprotection because it decreases cerebral palsy, especially if less than 28 weeks age of gestation. How does your magnesium sulfate work? To act as neuroprotective agent, it stabilizes the intracranial tone, minimizes fluctuations in cerebral blood flow, it reduces pre-perfusion injury, and blocks the calcium-mediated intracellular damage. Hence, it prevents cerebral palsy in preterms, and thus it makes the role of neuroprotection. Okay? Natandaan ha? Okay. So, magnesium sulfate, so you have a case. I would reiterate, a case scenario, okay? So, you have a patient who is preterm. Should you give, what tocolytic would you best give? Diba? Sabi natin, nifedipine. But do not combine at once with magnesium sulfate for neuroprotection. Okay? So you do first nifedipine. Later on na yung magnesium sulfate. Do you get it? Okay. Huwag mong pag-combine, papatayin mo yung patient. You will kill the patient. Okay. How about maintenance treatment? So after the acute tocolysis or prevention of uterine contractions, lysing the uterine contractions, do you need maintenance treatment? Do we need maintenance treatment of tocolytics? So you give further nifedipine, isoxaprine, kung ano man yung choice nyo. They said that there is no guidelines on uniform treatment of certain preterm labor after 48 hours of tocolytics. So it's not recommended. Maintenance treatment with tocolytics is not recommended. Okay. Until now. This is just to show you studies, the Apostel 2. Okay. So, to preterm labor, you have to give corticosteroids and tocolytics for 48 hours. The best one would be nifedipine. Maintenance tocolytics is not recommended. Okay. Okay. So, this is the table that I summarized for you guys. the tocolytic side effects for terbutaline, the pulmonary increase. This is a tocolytic that is with so much incidence of pulmonary edema. That's why we shun away from terbutaline use. Magnesium sulfate, likewise, would have a side effect of pulmonary edema. However, additional to that would be fetal fracture because of the bone loss of the fetus with the use of magnesium sulfate, especially if it is extended to 5 to 7 days. Okay? Indomethacin will cause oligohydramnios, PDA, and interventricular hemorrhage. Nitroglycerin, um, this can cause hypotension, maternal hypotension. And with the use of nifedipine, if with magnesium sulfate or IV salbutamol, and can cause cardiac arrest. So do not combine. Okay? Ayan. Yan yung important. Being doctor, you should know that. Okay? Ayan. It's a different story if you have PPROM versus preterm labor with no rupture of your membranes. One of the groups of the ward work showed this one. When you discuss, you just pick what applies to your patient and discuss the case. That's what I emphasize. This is from the 24th edition. For the 25th edition, ang additional doon lang is the use of magnesium sulfate for neuroprotection. Okay. I hope you are younger, so you are more adept, you are more voracious readers, ha? You've read your 24th edition, and you had repeated reading your 25th edition. Wow! Okay. Eto, this is the recommended management of preterm ruptured membranes, yung PPROM. Okay? So, again, I repeat, ha? It's a different story if you have intact membranes versus ruptured membranes in preterm labor. Okay? So, if you have ruptured membranes at 34 weeks or more or beyond, then deliver. Okay? You should be inducing your labor, and group B strep prophylaxis is recommended. When it is 32 to 33 weeks, expectant management by completing your corticosteroids, so that means 48 hours. Okay, antimicrobials, and then group B strep prophylaxis. When PROM occurs at 24 to 31 weeks, expectant the same, single course corticosteroids and tocolytics. There's no consensus in here yet. Antimicrobials plus neuroprotection. Yun ang wala dito sa 24th edition. But if it is before 24 weeks, yun, patient counseling na. Kasi very high ang neonatal mortality na, almost 99%. Okay. So the cutoff there, the threshold there, when to do delivery versus expectant management would be 34 weeks. 34 weeks up, deliver. Below that, at least you conservatize or tocolize for 48 hours for completion of your steroids, and then, of course, your neuroprotection. Not. Okay. So, by ACOG, in the management of PPROM, their stand is that expectant management at 24 to 33, 6/7 weeks, meaning you don't induce labor or augment labor. Okay? You don't really deliver at this age of gestation. But to complete the steroids and neuroprotection muna before you deliver. And PPROM outcome depends on the number of internal exam. Okay, the lesser the IE, better ang outcome. Use of tocolysis among this age group to complete the steroids again and neuroprotection. How about PPROM in the presence of cerclage? They advise cerclage retention. Okay. You don't have to remove the cerclage, the persistring in the cervix if you have PPROM. And okay, to prolong at least for steroids, for neuroprotection again. Okay, however, they found out that in PPROM decreased amniotic fluid, there is lung hypoplasia or underdevelopment of the lungs. Okay. Also, cord prolapse. They found out increased risk for cord prolapse, especially in non-cephalic presentation and less than 26 weeks age of gestation. There is the higher risk of cord prolapse. Okay. So again, if it is 34 weeks and beyond, deliver. How about the correlation of PPROM and chorioamnionitis? It would be increased, okay, incidence of chorioamnionitis through ascending infection from the vaginal microbiota, syempre. Okay, so the one that is causing chorioamnionitis would be strep, ano pa? However, in intact PROM, just to mention, yung Fusobacterium, they can invade or traverse the amniotic fluid membrane even if it's intact, yung Fusobacterium. Okay. Okay, the most important sign would be fever of 38 degrees and above. Okay, and also maternal leukocytosis. But between the two, okay, fever is a more reliable basis for chorioamnionitis. So what do we do if you suspect chorioamnionitis? Antimicrobial, like your ampicillin plus erythromycin, ampicillin sulbactam, okay. Of course, corticosteroids, and how about membrane repair or membrane sealants? Okay. It's not recommended. Yan. Okay, dapat nakikinig kayo children because I'm mentioning part of your exams already. Yeah. I'm summarizing for you kasi 2 chapters to. Okay. So, when to give magsulfate for neuroprotection? Again, and again. 24, 27, 6 weeks of gestation. Or in short, less than 28 weeks but more than 23 weeks. Okay? Kasi nga, patay ang baby if 23 weeks. Okay, so magnesium sulfate would primarily prevent cerebral palsy. So management during labor with those with PPROM, they recommend continuous CTG. Okay, however, routine episiotomy is not recommended in preterm labor, as well as outlet forceps extraction and CS to prevent interventricular hemorrhage. It's not routine. But what is routine recommendation during labor? CTG, but not episiotomy, OFE, and CS. Okay. And they found out that you would prevent interventricular hemorrhage if you don't have active phase of labor. You prevent active phase of labor, but no one delivered without passing the active phase of labor. It's just a study. Ayan. Any questions? Okay. So, management, diagnosis, management of preterm labor would be based really on best available evidence. So the ones that we mentioned that is recommended, not recommended, you follow it up because before all you know, in 3 to 5 years, it's already not recommended, and the ones not recommended now will be recommended. Kasi sa tagal kong nagtuturo ng preterm labor, dati FFN is recommended. Ngayon, hindi na as a sole ano. Okay. And also consider clinical expertise, experience, skills, and judgment. Okay. And of course, patient needs, values, and preferences. You combine the three, PBM, clinical expertise, and of course, do not ignore the needs of your patient. That is your basis for the management of your preterm birth, but the heart of it would, of course, TBM. Kasi nga, doktor ka, hindi ka kwak-kwak. Okay. Oh, bladder break, and then I will prepare the 5 minutes bladder break. I will prepare the post-term. Saan na ang post-term? Yeah. Ito ko yata nilagay. May sukle, manang. Ay, sorry. Sukle. Okay. Wala pang ano, call. Bakit Peter ang nakalagay? Okay, shall we continue?
Yes po, Doc.
Kasi konti na lang yung oras pala. We only have 32 minutes. Okay, so we proceed with the post-term pregnancy. So with that, we have to, just like your preterm and preterm birth versus preterm labor versus prematurity. So you have to to take note of the terminologies. Okay. So post-term pregnancy should be differentiated from post-mature. So when we say post-mature, it is used to describe the infant with recognizable clinical features indicating a pathologically prolonged pregnancy. Okay. We will look into it, ano ba yan, pathologically, clinical features. So by ACOG, post-term or prolonged pregnancy is a 42 having 42 completed weeks or 294 days or more from the first day of LMP. So, the terminology that is preferred is the post-term or prolonged pregnancy, not the post-mature or post-date. Okay? Yan. And post-date should be already abandoned. Okay. So, yan. So, post-term, no. Yes. Prolonged pregnancy, yes. Post-date, no. And post-mature, no. Because post-mature, that's the baby itself who was born post-term. And more than 42 weeks. Post-date kasi, pwede more than 40 weeks. Pero, anong date? What date are you referring to? That's their question. Post-maturity or post-mature is a specific syndrome of infant. So the incidence of post-term basing on the LNP would be 7.5, by ultrasound on 2.6. Combining the LNP and early ultrasound as a basis of post-term would reduce it to 1.1% in incidence. Okay? So, meaning early ultrasound would be more reliable than the LMP, but combining the two would be best. Give you the age of gestation. Okay? So, like you're in history of preterm birth, post-term would also tend to repeat itself to happen in the succeeding pregnancy. Okay, the more post-terms, the more risk to have a post-term pregnancy again. Incidence-wise, it ranges from 4 to 19% of all pregnancies. Okay. So, using the LMP as a basis, okay, using the LMP, yan, ulyanin kasi ang patient, there is the error in gestational age estimation because of faulty menstrual date recall or delayed ovulation. Remember yung the usual ovulation is 2 weeks, right? 14 days. Sometimes there is delayed ovulation for some, as for those who are oligomenorrheic. Okay, so the interval is longer, like 35 days. Okay, so menstrual dates are frequently inaccurate in predicting post-term pregnancy, but ultrasound is a better one. Okay. So etiology of your post-term would be primarily wrong dates. Biological, previous prolonged pregnancy, irregular ovulation, decreased fetal estrogen production like in the cases of placental sulfatase deficiency. Ano yan? Sino yung may placental sulfatase deficiency? Those with ichthyosis or syndrome. Anencephaly, why? Because of the underdevelopment of your HPO, your hypothalamus pituitary glands, fetal adrenal hypoplasia. Okay? And of course, extrauterine pregnancy. Post-term ka lang post-term, hindi pa rin nanganganak because it's not intrauterine. How would that baby go out or be delivered when it is in the abdominal or extrauterine? Okay. So the risk factors are as follows: the parity prior post-term birth, socioeconomic class, and the age. Okay? And BMI of more than or equal to 25, and nulliparity. So, the nulliparous would tend to have post-term pregnancies compared the multiparous. Ayan. Okay, so the physiologic changes associated with postpartum pregnancy would be as follows: placental changes, amniotic fluid, and fetal changes. So what will happen with the placenta? Remember, there is senescence or aging or apoptosis, okay, that happens in the placenta as presented in the ultrasound as infarcts or calcification or whitening. When it comes to amniotic fluid, with postpartum, you will have oligohydramnios or diminished fetal urination. Okay, and could be seen as cloudy or flakes of vernix gaseosa, and sometimes presence of meconium because of natural physiologic uh, bowel movements of the fetus in utero that they would excrete meconium or the first feces. Okay, when it comes to the fetus, they tend to become macrosomic or big LGA at that when you have a postpartum pregnancy or prolonged pregnancy. Yan. So, the perinatal mortality and morbidity correlated or associated with postpartum would be based on the intrapuertum fetal distress as a consequence of cord compression because of oligohydramnios. Okay, the baby should be, the fetus should be freely moving inside the womb, inside the uterus in the presence of adequate amniotic fluid. But with aging or postpartum pregnancy, the amniotic fluid is decreased because of senescence of the amniocytes in the amniotic fluid membrane that produces your amniotic fluid itself, and of course decreased urination of the fetus. Yeah. Kasi decrease ang ini-engulf na niya amniotic fluid. Okay. So, the major causes of death in postpartum would be gestational hypertension, prolonged labor with cephalopelvic disproportion because of macrosomia, and unexplained anoxia because mostly of placental senescence or apoptosis. The cells in the placenta would apoptosis at 40 weeks age of gestation na, and sometimes malformations. Other morbidities correlated with postpartum would be cerebral palsy, primarily because not of, unlike in prematurity, underdevelopment, but rather because of hypoxia. Lower intelligence quotient because of hypoxia. Cesarean delivery for dystocia because of macrosomia, fetal distress, of course, and intensive care unit admission, secondary to meconium aspiration syndrome. However, autism is not part of the morbidity that is related to postpartum. Part. Okay. Here is a post-maturity syndrome picture. So your baby would have wrinkled skin. Nakita nyo? Wrinkled skin. That's in your book again. Ayan. Who would love a baby who has wrinkled skin? Di ba? Dapat hindi. Mukha siyang old. Okay. Post-mature newborn infant has wrinkled, patchy, peeling skin, and long, thin, wasting body, suggesting advanced maturity. Okay? So, oligohydramnios is defined as less than or equal to 1 centimeter volume at 42 weeks. And that is secondary to placental dysfunction as well as loss of protective effects of vernix gaseosa. Kasi magdi-decrease na. Because of placental senescence, they become old, or placental apoptosis, which is a programmed cell death. Okay? As seen in the genes kiseptin and cord blood erythropoietin, which increases. Meaning, with increased cord blood erythropoietin, that is a compensatory mechanism to hypoxic events in the placenta because of senescence or apoptosis. Okay. So, fetal distress and oligohydramnios are correlated. Okay? And take note, at 38 weeks, it will downhill na yan, ang production of amniotic fluid. And more so when it is more than or equal to 42 weeks age of gestation, urine production is decreased because they have decreased involvement of amniotic fluid na because of decreased production from the amniocytes. Ulit-ulit na lang. No? Okay. When you evaluate with Doppler ultrasound, there is decreased renal blood flow as well. As a consequence of oligohydramnios, there will be cord compression, viscous meconium, resulting to engulfment of meconium, resulting to meconium aspiration syndrome. Another one is nuchal cord. If you have nuchal cord, more cord compression resulting to distress, fetal distress. Another thing to take note in postterm will be fetal growth restriction. In those patients who become postterm and have issues and who are IUGR, they are more prone to end up stillbirths. Okay, so IUGR plus postterm or more than 42 weeks age of gestation, greater risk to have stillbirths. Bakit wala ng camera si Asifur? Oh, sige, yung iba pa. So, complications of postterm maternal wise anxiety. Yan. They get worried why they are not yet. They are beyond the expected date of confinement. Traumatic vaginal delivery because of shoulder dystocia secondary to macrosomia, and sometimes they end up for cesarean delivery. And of course, hemorrhage. On the fetal side, we have the fetal distress, meconium aspiration syndrome, fetal trauma like the brachial plexus injuries, clavicular fracture because of dystocia, increased perinatal mortality as well, and dysmaturity syndrome. So, oligohydramnios is diagnosed clinically with ultrasound. Okay? So, dealing with patients with oligohydramnios, they have this one statement that I got there, that reassurance of continued fetal well-being in the presence of normal amniotic fluid volume is tenuous, because you cannot really get the exact measurement of the amniotic fluid. It's only through ultrasound by getting the largest vertical pockets and a measurement of less than 1 to 2 centimeters, that's already oligohydramnios. And when you make use of the 4-quadrant amniotic fluid index, it should be less than 5 or 6, or an amniotic fluid index of less than the 5th percentile. Okay, so actually it's not an exact view of the amniotic fluid. Another issue with postterm is macrosomia. Take note that there is increased the weight gain peaks at 37 weeks. So beyond that, gain siya ng gain. And this would result to fetal injury because of difficult delivery or dystocia. So what we do to prevent macrosomia, it is mitigated with timely induction to preempt further growth. However, what is macrosomia? Let us define what is macrosomia. In the absence of diabetes, the macrosomia is defined as estimated fetal weight up to 500 grams. But in the presence of diabetes, it's 4,500 grams. Okay. So when to do vaginal delivery versus cesarean delivery in macrosomic? If no diabetes, sige daw, vaginal delivery in 500 grams. If with diabetes greater than 4-5, you do cesarean section, and those with prolonged second stage of labor or arrest of descent. So, it's an obstetric indication pa rin, not merely on the basis of estimated fetal weight of macrosomia. Kuha? Okay. So, medical or obstetrical complications of macrosomia. Okay. So, generally, it's not recommended that the pregnancy be allowed to continue past 42 weeks. So, early delivery is indicated, especially those who have gestational hypertension disorders, prior cesarean delivery, and diabetes. Okay? So, the management of postpartum, uh, it depends on the timing, and interventions. Okay, but there is no unanimous decision on when to induce, what kind of intervention are you going to induce, with what? Okay. So, the issue now is that either to induce labor versus expectant management with fetal surveillance. Okay, in postterm. So by ACOG, 75% of postterm are routinely induced at 41 weeks. So ang recommendation nila ay 41 weeks. Even in WHO, when it is 41 weeks and it's not in labor, admit the patient and induce the labor. Okay? But there's still a room in around 25% for those at 41 weeks that they do fetal surveillance twice weekly. Okay? At 40 until 42 weeks. So 42 weeks and beyond, admit and induce na rin. That's for the other 25%. Okay? Okay, so who would have successful induction now if you admit it at 41 weeks age of gestation as recommended by ACOG and WHO? Okay, who among them that you admitted for induction would be successful? It depends now on the Bishop's score. Okay, which one is a favorable cervix for induction? Bishop's score of more than 7. Some books would say more than 6. Okay, some would have more than 9. Pero we will stick with one, more than 7. Okay. But the one that is unfavorable for induction is Bishop's score of less than 7. When we say unfavorable, there is no cervical dilatation. Okay? And if there's no cervical dilatation in studies, there is 2 times cesarean delivery rate for dystocia. There's 10 higher risk for you to have cesarean section if you have a Bishop's score of less than 7 and no cervical dilatation. Also, cervical length of less than or equal to 3 centimeters at transvaginal ultrasound is predictive of successful induction. Okay, so yan yung mga findings. Okay. Ano ba? So, in summary, if you have a Bishop's score of less than 7, if you have no cervical dilatation, failed induction yan. But if you have a cervical length less than or equal to 3 centimeters, most likely you have successful induction. Ibig sabihin, the patient will deliver vaginally. Okay. To have cervical dilatation, first and foremost, you have to soften the cervix or you will have to thin out through cervical ripening. Okay. So, what are the agents what are the methods that we use to cause cervical ripening or thinning out of the cervix? We have the prostaglandin E2 and sweeping or stripping of the membranes, which we recommend at 38 to 40 weeks age of gestation. However, sweeping and stripping of the membranes is not routinely recommended at 38 to 40 because it causes undue pain, vaginal bleeding, irregular contractions without labor. Okay? So, hindi nire-recommend ang routine sweeping or stripping. Kuha? Okay, another factor would depend on the station of the vertex. So, the higher the station, the more tendency to have cesarean delivery. Or the opposite, the lower the station, the lesser the tendency to have cesarean section. Ganun lang siya. Okay, so now the dilemma or the caveat is to induce ba or to do fetal testing? Observe and do fetal testing. Okay, in unfavorable cervix, there is marginal benefits for induction. Okay, kasi less successful. So, you have to do fetal testing beginning after 41 weeks age of gestation. How do we do fetal testing or monitoring? We can do counting fetal movements in a 2-hour period each day. So, you count a decreased fetal movement, for example, on the first hour, 5. Second hour, wala na. So, decrease fetal movement yon. Another is non-stress testing 3 times weekly. CTG ka, 3 times a week. Amniotic fluid volume assessment 2 to 3 times weekly with pockets less than 3 centimeters considered to be abnormal. Okay? Okay. So, however, they found out in the side of labor induction, there is higher cesarean delivery rate. Okay. So overall, the management of postterm, first and foremost, you have to confirm the gestational age. Is it really postterm to begin with? Okay. It can be based on reliable LMP, but the problem is that if the LMP was not known, diba? Versus known. No OCP for 3 months, regular cycles. That's the one that is applicable for LMP. So we consider it reliable if it is known. No OCP use and with regular cycles. Okay. Another would be first trimester with the use or measurement of crown ramp length. That's the most reliable among the ultrasound. Second trimester, making use of BTD. First trimester, pelvic and vaginal examination, Doppler, FHT at 10 weeks, and quickening at 16 to 18 weeks. So there are many ways of confirmation of gestational age, okay? But the best would be first trimester CRL ultrasound. Further, with ultrasound, um, other than establishing the age of gestation, with early ultrasound, we can repeat ultrasound to measure AFI if less than 5, considered as oligohydramnios, which is correlated with postterm. Another is estimated fetal weights ultrasonographically, and they tend to be macrosomic. And the placental grading as grade 3, and if with a lot of whitening or calcifications, more of poster. Pelvic and vaginal exam to assess inducibility with Bishop's score. So, so we agreed, uh, more than 7 dapat, or equal to 7. Okay. Eto, this is just a algorithm. The ones who would need delivery in poster, right? Cervix, oligohydramnios. So, ibig sabihin, the Bishop's score is more than 7 or equal to 7. Oligohydramnios, macrosomic, abnormal NST or BPP or CST, meconium stained liquor, then deliver. If unripe or unfavorable cervix, Bishop's score of less than 7, normal fluid, amniotic fluid of more than 5, normal lahat, then you have to do IE, assess for Bishop's, further NST, AFI weekly at 40 to 41 weeks, twice weekly thereafter. Okay, if it is already right, you go back there, illegal, abnormal, and it's already 42 weeks, then by all means deliver. Okay. So when it comes to delivery, we have the induction of labor and antepartum fetal testing, and it should be done at 41 and 42 weeks. By all means, 42 weeks na, di ba? Okay. However, initiation of fetal surveillance is recommended at 41 weeks, and after completion of 42 weeks, antenatal testing or labor induction na siya. So, this is from your book again. At 41 weeks, no other complications, start fetal surveillance. If still undelivered, 42 weeks, no complications, labor induction na siya. Okay. Sorry naman yun. Okay. If with complications like fetal compromise, oligohydramnios, then induce labor. Yan. Take note. This is the stand. No interventions are practiced solely based on fetal age until 42 completed weeks. So, hindi mo i-deliver just because it's 41 weeks, 44 approaching 42 weeks. Unless, okay, you have to do an intervention if they have hypertension. Decreased fetal movement, either observed or reported by the patient. Oligohydramnios of less than or equal to 5 centimeters, you have to deliver. So first, they found out on the first induction attempt, almost 90% would be successful within 2 days of induction. If still unsuccessful, second induction should be done within 3 days, and almost all women are delivered. And the rest on the third induction attempt, CS na siya usually. Okay, that's the antepartum management. We go now the intrapartum management. What is the recommendation? Patient should be placed on left lateral position to decrease the aortocaval compression that may cause hypoxia as well as cord compression. Ayun. Because of oligohydramnios. Continuous electronic fetal monitoring, just like your preterm labor. Early amniotic rupture of membrane in active phase that will hasten progress and detects meconium is not routinely recommended. And reserve LTCS for cesarean section for cephalopelvic disproportion or macrosomia, fetal distress. The use of amnio infusion for cases of oligohydramnios with the use of 750 to 1 liter NSS or lactated ringers if meconium, stained liquor, and with variable deceleration. But as a routine amnio infusion for treatment of oligohydramnios in postpartum is not recommended. And of course, during delivery, pediatrician at delivery should be available because in anticipation to fetal distress and meconium aspiration that should be suctioned at once. Wala na yata. Or wala na ako. Okay, that's it. I think that's the last slide. Okay. Guys, I hold you responsible to read your books. Okay. Almost 95% from your Williams. Okay. Williams 24th, but ideally it should be 25 in 25th edition. Asan na yun? Okay. Ayan. Wala na. That's it. Any questions? May questions ba? Who is absent? Sino absent, children?
But we will double check the attendance from Sir Eric later.
Okay, sige please. Kasi it's a waste of time naman. If we call you one by one, we're no longer grade 2, grade 1 elementary. Ano yung orasan? 3 minutes na lang. Okay. during your kailan ba ang LE ninyo dito?
So, I think next week po for OB. Ay, December 4 po.
December 4. December 4, LE, OB2. Okay. We will have a quiz. 20 points. 20 points na quiz on this topic. Okay. Set a date or together with the LE or right after the LE. Do you get it?
Okay po.
The class should decide on that. Do you have questions? May questions po ba kayo? On pre-term and post-term delivery. Wala? Sige. I assume that it's clear, but I encourage you to read the books. Okay, bye. Get the attendance, ha?
Thank you po.